Thank you, Dr. Moreau. That was a masterly talk, and no wonder, being you're the guru in the field of ACLF, and so much of information you put together in such a short time, 45 minutes. That was wonderful, and we learned a lot today. And the talk is now open for a discussion. Please, I want to ask the audience to, put their questions in the chat box, and also, if you have any questions, please raise your hand so we can go in order. So I see that Dr. Abbas, you want to ask a question. Seems like the video is on.
Yes, it's always a pleasure to listen to Professor Moreau. So, I get confused sometimes when I see a patient of MASLD who presents with ACLF type 3. Should I call this ACLF or acute liver failure? And second question is, what's the role of GCSF in these patients?
Yeah. These are two excellent points. In fact, to me, patient with MSLD and grade 3 ACLF should be considered as ACLF and acute-on-chronic. But we need to have more information on these patients. We don't need, in fact, in particular, the impact of new therapies on the natural history of this patient. And when we ran the ACLARA study, we were extremely surprised that patients with MASLD treated with anti-diabetics had the lower prevalence of ACLF than the other patients. Therefore, probably there is a very important, finding here, and we are eagerly waiting for the results of the new drugs on the natural history of this patient. Regarding GCSF, I didn't allude to this because we had in Europe a negative trial, and therefore the EASL Clinical Practice Guidelines didn't recommend to use GCSF in patients with the ACLF. I agree with this recommendation because patients with ACLF already have, this is universal, they have neutrophilia, an increase in neutrophil count, I would say at baseline, and therefore increasing more neutrophil count could be deleterious instead of...
Let me invite Dr. Dharmesh Kapoor from India, prominent hepatologist. Dr. Kapoor, please, thank you for joining as well.
Hello, Professor. That was a wonderful talk, and obviously your last slide and the last statement of the last slide was the punchline for me, that the research agenda is very busy. So I think this is still a work in progress in spite of whatever we have done for all these years. And the more we try to unravel this mystery, the more difficult questions it begins to pose to us as to what we have to do by way of management. So one has had problem with all the three definitions. Of course, you were right in saying that the CANONIC study was probably one of the finest studies in clinical medicine in recent times, because it was done over a very short period of time and the results were read out very quickly, something that you don't see in this day and age. But what really strikes as an odd point is that figure of 15%. So that was a look back figure. That was not something that you were trying to look at prospectively. Of course, there are gaping holes in the other definitions also. And for those of us who care for chronic liver disease patients who are critically ill, a sick liver disease patient means different things to different people. And some of those patients might be out of realm for any of the definitions that you've given to us. So that's on a philosophical note. Now, the question that I wish to pose before you is, what are your own thoughts on the use of plasma exchange in patients with acute-on-chronic liver failure. Let's forget for the time being what the results of the ongoing trial are going to read out. What are your thoughts on the use of plasma exchange in this condition, sir?
Look, I can tell you that we are impressed by the results obtained with the plasma exchange in patients with ACLF. We have enrolled already almost 200 patients prospectively, and the efficacy of plasma exchange is impressive. Therefore, of course, I cannot say more. I cannot recommend the use of plasma exchange, but for sure, I'm sure that the trial will be positive, and I'm sure that the use of plasma exchange will change totally the landscape in the next years.
Sir, do you feel that it's going to alter the transplant-free survival?
Yes.
Right, because that would be an emphatic gain. Because anything else short of improvement in transplant-free survival, might not hold its ground.
Yes.
Thank you, sir.
This will be game-changing.
That's very interesting to hear from you, Dr. Moreau, that you are pretty much kind of advocating, looks like, or very much gung-ho around this plasmapheresis, and you think like this is going to be game-changing. We'll see what the result comes in, but it sounds like, are you using in routine practice outside this clinical trial plasmapheresis?
I can tell you some colleagues are using plasma exchange outside trial. Therefore, they do not follow the recommendation made by the European experts, but because the results are so spectacular.
I see. And then you use a small volume or the large volume plasmapheresis or plasma exchange?
Large volume. Large volume.
Okay. Thank you so much. May I invite Dr. Benedict Maliacal, who is a transplant hepatologist and at Nashville, Tennessee. Dr. Maliacal, please.
Hi.
And actually, just let me tell you, Dr. Maliacal is part of the NACSEL, and he has published numerous studies in ACLF along with Dr. Bajaj.
Yes, I know.
Thank you very much, Dr. Moreau. I have been a proponent of plasmapheresis from very early, because if you look, the liver is the most important organ for clearing microparticles. And microparticles are formed with any organ damage or sepsis. And so when microparticles are increased in the circulation, they cause cellular dysfunction, leakiness, immune issues, inflammation, and everything. And because the liver is the only organ actually in the body that clears, and a normal healthy liver protects other organs, whereas a liver that is already sick, and if the liver has got more insult on that, instead of clearing microparticles, it will add to the load. And so it makes very good sense to do plasmapheresis early before organ failure sets in. Now, the key thing is there's very poor research in microparticles. I've read everything that is there for the last 5 years, and there's no quantification. There's also helpful microparticles because organs communicate and cells communicate with microparticles. So when we remove all microparticles, we are taking some good with the bad, so we may have to add something in. So I think that is where the research should be going in terms of plasmapheresis. And again, large volume makes sense because, again, there's a large number, billions of microparticles per ml of plasma, and because they do get into the cells and cause inflammation, just giving cytokines or cytokine inhibitors is not helpful. Removing the root cause is the most helpful, and that's why plasmapheresis will work. And it will work if it is done early, before multiple organ dysfunction supervenes. And that's what I wanted to mention. The other two things are, I wanted your comment on the PREDICT study, because the PREDICT study makes us wonder if we can ever predict, who will go into ACLF, and that is a big problem. And the third last thing is, I think we need to shift our focus to identifying people with cirrhosis and preventing the first onset of ACLF, because I think that is where the biggest benefit we can give to our patients. Thank you.
Thank you for your comments, and I fully agree that plasmapheresis probably should be used very early in the early in the course of the disease, at least I would say at the pre-ACLF stage, and as you mentioned, the PREDICT study didn't succeed to identify clear distinctive features for pre-ACLF versus unstable decompensated cirrhosis or stable decompensated cirrhosis. And I can tell you that it is so important to identify these patients with pre-ACLF before developing ACLF. So important to identify them, to start treatment very early, that we are working actively on this topic, and I can tell you that we progress in very significantly in identifying these patients with pre-ACLF, in particular with the use of some gene signature which are very accurate, but these are not yet published results, but I hope that we will be able to present these results next year.
Thank you.
Thank you so much. May I invite Dr. Prasoon Jalal? Dr. Jalal, please.
Thank you. It's really a masterly talk. Thank you, Professor Moreau. The way I see it, the differentiation between acute liver failure and ACLF is probably going to be more blurred, because with methyl alcohol staying in the background, do you feel, the way we see it, that the complications from liver disease, then some precipitating event is happening, whether it's infection or other drugs or toxins leading to ACLF and leading to organ failure? Do you feel that we need to redefine the definition of acute liver failure? So that's one question. And second thing is, we talked about plasma exchange. Obviously, that's very helpful, the way I see it. But not every place can do it. In practical terms, first organ gets hit is kidney. Do you feel we should, the management side-wise, we should start early CRRT or renal replacement therapy, which may be able to prevent the other, succeeding events and leading to other organ failure?
Regarding the second point, we don't have evidence for this, and I think that this is a very important question. If plasma exchange is so effective, how can we manage this patient when plasma exchange is not available? And this should be addressed in prospective trials, and until now, I have no answer for this. The first question was related to acute liver failure. Your question was about the criteria used for defining liver failure in our patients, or maybe I missed I didn't catch
the criteria
the
we
question.
use for defining acute liver failure
Yes.
in general, and because the reason we use it to prognosticate, and again,
Yes.
for early liver transplant. But I feel like with these, alcohol or methyl in the background and other chronic liver diseases being recognized, we may need to redefine that.
Yes. I fully agree. And interestingly, we will have in San Diego during the ASLD meeting an expert meeting, I would say, during which we will try to redefine liver failure in particular. And I think we should wait for this meeting before answering to your question. I'm sure that there will be very interesting proposal during this meeting.
Is it a part of your chance or separate?
No, it's separate. It's I would say private initiative by Jas Bajaj, Patrick Kamat, Shiv Sarin, myself, and Debbie Shawcross. And we will address how to improve the definition of each organ system failure, and personally, I'm waiting for the talks on liver failure, like you.
And
so let's wait for the ASLD.
Yeah. Is it more internal discussion, or it'll be open to everybody?
No, it's at that time an internal discussion, and but I'm talking about this because probably we will publish a document afterwards, and therefore you will have the information, the requested information in this document. Yes.
Thank you.
Thank you. And now may I move to Dr. Raj Verma. Raj Verma, please introduce yourself as well.
Hello group. Happy Diwali to all those who celebrate. I am in Minneapolis. I am a part of a big private practice group here. I have a very simple practical question for my own learning regarding alcoholic hepatitis as a cause of ACLF or the initial ACLF. I know that infection is of course a strict no-no. However, the other two contraindications where it is said that renal failure or GI bleed is a contraindication for use of steroid. So what is your practice style in the group as to at what cutoff for creatinine or GFR would you absolutely not use steroids in acute alcoholic hepatitis? Or if it's a non-varicose upper GI bleed, let's say just a gastritis or esophageal ulcer or something else that caused some melena, would you consider it as a GI bleed and not use steroids, especially when I've seen that, let's say, another team started someone on steroids and the bilirubin and INR within a couple of days rapidly continued to improve? Would you still say that, well, there was GI bleed or there is elevated creatinine and would not use steroids in alcoholic hepatitis as a cause of ACLF? Thank you.
It's a very tough question because using corticosteroids in bleeders is always a problem. And in fact, we use corticosteroids in bleeders when we are sure that the source of bleeding is the varices, for example, and not another lesion of gastritis or something like that. So this is not an absolute contraindication to corticosteroids. Regarding kidney function, this is very tough, and I would say that the serum creatinine, the level of serum creatinine beyond which corticosteroids should not be used is around 0.53. Yeah?
Thank you. Thank you, Dr. Moreau. Now, may I invite my former mentor, Dr. Yogesh Chawla. Dr. Chawla, thank you for joining. And I would love to hear a few words from you.
Yogesh. So nice to see him.
Hi, Richard. Lovely seeing you.
Yes.
I
yes.
partly heard your talk, So it was very interesting. Questions have been very interesting. But what always bothers me is the canonic definition of ACLF does not include liver dysfunction or failure as an important organ involvement. While you call it as acute-on-chronic liver failure, you have all the other organ failures. Liver is not given that much importance. So I've not been able to get an answer to this. What are your comments on it?
Yes, this is yes. First, I'm so happy to see you. And are you in Chandigarh? Yes.
I'm in Chandigarh.
Yes.
Very much.
Very good. Now, in fact, we kept. You are totally right. The term ACLF, acute-on-chronic liver failure, maybe is not appropriate, but you know, it was so widely used in the community of European hepatologists because it was used for the first time by Roger Williams and Rajiv Jalal, that we finally decided to keep this terminology, and for sure in the future maybe the next generation hepatologists will change the semantics and find more appropriate, I don't know, cirrhosis with organ failure or something like that, you know. And but I realize that the terminology is not perfect, because at the end, if you change the liver, you change the landscape, and you change totally the prognosis of the patient. Therefore, the liver is the master. And there is a sort of paradox, because when we use the EASL ratio for death as a tool for determining the cutoff of the CLIF COF score, we have to consider very high level of bilirubin to make sure that we capture very severe patients. Therefore, there is a paradox that should be probably studied and in the future, yes. And but you know, ACLF now is popular, and
right.
It would be very difficult to change the terminology.
Right. Thank you very
Sanjay,
much.
can I just chip in? Sir,
Of
can
course.
I just chip in with your permission?
Absolutely. Please go ahead, Dr.
So Professor Moreau, this particular discussion happened before the last consensus of the APASL definition was made, and I was given the task of making a presentation to bridge the gap between the APASL and the canonic definition. Now the thing is that the canonic definition is nothing but a spin-off from the SOFA score, which was given by Lulu Vincent many years ago, and which we as ICU physicians have been using for almost 2 decades plus. Now, if you were to shift the bar of serum bilirubin a little leftwards, so rather than saying more than 12 milligrams, if you were to include 6 to 12 and then have a look back on your data as to how many patients will indeed have liver failure, because the APASL definition is 5 milligrams per deciliter.
Yes,
your definition is 12 milligrams per deciliter. So if you were to shift the goalpost just a little leftwards, one might find a common ground.
Yes, I fully agree. And we are working with our biostatisticians in different scenarios, you know. I'm not, I do not close the door. I'm very open. And right now we are trying to improve our criteria, and therefore because we have already 6 organ systems, therefore the number of combinations is very large, and we are considering, I would say, the different scenario, in particular the scenario where the cutoff for liver failure is decreased to let's say 5 milligrams. Yes, I not yet the answer.
Thank you, Dr. Kapoor, again for chiming in. May I ask you one question, Dr. Moreau? Going back to the earlier questions or discussions around plasma exchange, do you think the plasma exchange should be reserved for ACLF2 or ACLF3 or more severe? Or do you think the plasma exchange would be more beneficial early on, even before developing or progressing to ACLF2 and 3?
Yes, this is a very important point, and but I have no answer. I think that if, for example, if you want to use plasma exchange before ACLF development in patients who are candidate to develop ACLF, therefore patients with pre-ACLF, we don't know how the plasma exchange would work, but for sure this should be investigated. But the first point would be to identify to make sure to identify the right patients with diagnostic criteria for pre-ACLF, which are robust and solid, you know. If we have solid diagnostic criteria, we can test every kind of preventive therapies, you know, because these patients with ACLF are so severe that it would be nice to intervene upstream in the trajectory, yes.
I think in some of your earlier studies, you have, particularly the pre-ACLF patients, you have shown the levels of cytokines, IL-1 and all these different cytokines. And the patients who had the highest level of cytokine, they progressed to the various stages of ACLF. Do you think those could be a candidate? Like, just hypothetically, I'm asking, those may be potential candidates who might benefit with ACLF with the highest level of cytokines.
Yes, yes. And also, currently we are investigating the possibility to develop some gene markers which capture alteration in the circulating immune cells, which are very sensitive to of course, to cytokines, but very sensitive markers for the prognosis and the outcome of these patients. Therefore, we are looking at this. Cytokines are interesting, and maybe also the gene markers for immune cells, you know. But it's too early to tell you more, you know.
Again, thank you so much for that. You also mentioned in your presentation, that was a fantastic slide we came across, the research ideas around ACLF. One slide pertaining to a number of different directions, including sarcopenia and frailty. I think that will be a very interesting area to investigate, because ACLF, aside from the organs, I think the muscle itself is an organ, and that has not been included. And we know that sarcopenia and frailty do affect, irrespective of the severity of the ACLF, do affect outcomes. And so could that change? Are you open to add that into your organ definitions of this ACLF?
Yes, it would be. In fact, we are working on this because we would like to have biomarkers for I would say muscle sarcopenia or frailty. We have identified in blood of patients who are very severe patients amino acids which are released by the muscles, in the context of AD or the context of ACLF, and I think that this marker could be used as surrogate of the current tools which assess frailty and sarcopenia. We have to develop these biomarkers. The same for hepatic encephalopathy. The problem with the hepatic encephalopathy is very subjective, very difficult diagnosis. Therefore, we are looking for metabolites in particular, which are good marker for hepatic encephalopathy, could be used instead of the West Haven in the scoring system, you know. And of course, for each organ system, it would be nice to have very, very robust biomarkers. Yes.
I would like to thank the audience for such an engaging discussion and staying till the end. And I also like to thank Professor Moreau for giving his very valuable time for this lecture. This was such a wonderful lecture. I learned a lot personally, and I'm sure our audience also learned. And those who have missed, they will also listen to this talk. It will be on the website with Dr. Moreau's permission. And
Yes.
questions, if there are any further questions, and you definitely can put it in that website, or you can send it to us, and we will pass it on to Dr. Moreau.
Yes.
We really appreciate you all joining, and we look forward to see you again in about 2 weeks, and we'll send out an email with the following next lectures as well. So thank you again. Thank you, everyone. Thank you, Dr. Moreau. Thank you so much.
Thank you. Thank you for the invitation again.